SWFT. Delighted to see so many members of the public with us. And we're going to start today with our celebration of our Going the Extra Mile winners. This is a roughly monthly event where we celebrate individuals and teams who have definitely gone the extra mile. And I can see Donna in her sunglasses by the looks of it in her car. We'll come to you in a second, Donna. But our first is the individual winner of the Going the Extra Mile award, and that's for Marina Graham. Marina, I can't see you on the line unless you can wave at me. Marina, hey, well done. Lovely to see you. So I just want to read out your nomination, Marina. And it wrote, it says she's been nominated 5 separate times for a Going the Extra Mile award. One nominator said she has a patient-centered and holistic approach, meaning that she initiates and encourages patients to engage in a wide range of activities. This includes things as simple as making their own bed, taking them to the local cafe if appropriate based on a risk assessment, and supporting and leading small group activities. The whole multidisciplinary team comment on how invaluable Marina is, and we often say, if only we could duplicate her. Another nominator said, I've worked with Marina for many years, and she's constantly and consistently going the extra mile for our patients. She embodies all the trust's values of safety, trustworthiness, compassion, inclusivity, caring, and being effective. Another comment was she's bought in clothes for patients that are homeless, and she will even go to the canteen and get them nice things to eat out of her own pocket. And Marina, you are an absolute star. You do truly embody everything we want to achieve as a trust for all those patients and families we look after. So on behalf of the whole board, you are absolutely a worthy winner of our individual Going the Extra Mile award. Thank you, Marina. You're a star. And then we get on to our team winner. Now, one of the, I think, absolutely saddest things that can happen in one's life is to lose a child. And our team winner, on a daily basis, the team do a fantastic job of helping and leading our maternity bereavement team. So the bereavement midwife is Sarah Barnes. Donna McKendry is our maternity quality improvement and communications assistant. Emily Patterson, who's one of our midwives, and Susie Sharp, who's our quality assurance lead midwife. You are that bereavement maternity team. And so you're our spring of 2024 winners. You did some fundraising activities during Baby Loss Week, which was last October, and the team raised over £5,000 for the refurbishment of the bereavement Xena Suite on Labour Ward. This is the most that has ever been raised by a team. The nominator said, this was something that the team did off their own back and is a record-breaking fundraising achievement. People dedicated their own time to support the fundraising efforts. They will support bereaved families in being able to have an improved experience in what is an absolutely nightmare situation when they're going through a really challenging time where they will have to birth a sleeping baby, saying their goodbyes and arranging a funeral when they were expecting to be taking a new baby home with them. What you do day in, day out, or not, unfortunately it's not day in, day out, but you take the point, what you do month in, month out with those families is so important, team. You are absolute stars. Thank you very, very much. You're our Going the Extra Mile team winners for spring 2024. I'd also like to shout out a particular individual. We had a great session, board workshop this morning. We particularly did some work on workforce productivity, and I want to shout out to someone in the finance team, Vicky Gunawardena, who does a fantastic job in pulling together the data, making it understandable for everyone that's involved in helping us drive forward the productivity agenda. So Vicky, well done. Thank you very much, and carry on with the great work. So without further ado, we'll get into the main body of the board meeting today. We have apologies from Yasmin Becker, Yasmin, you're in our thoughts, given your recent bereavement. Sophie Gilgs, great to have Jenny Bannon with us, deputising for Sophie. So any new declarations of interest? Could you please raise a digital hand if you have any new declarations of interest? Okay, can't see any digital hands raised. Can I ask everyone to go on to mute for me, please? The last set of minutes, the meeting held on the 3rd of April. If there are any amendments to those minutes, could you please raise a digital hand for me? Can't see any digital hands raised. So we'll then move on to the matters arising, which is on page 12 of the pack, 12 of 409. The first was David and the Clinical Governance Committee to investigate with relevant officers what the capacity for safe maternity services would be for it not to become compromised. Where are we, David, with that complex discussion?
Yeah, we're further on than we were in that the Birth Rate Plus report has actually been published and received, and in fact a summary of it is appearing in the perinatal report later on in the meeting. That has highlighted a number of issues relating to the increased activity, but actually also, perhaps more importantly, the increased complexity of the births that are happening at the trust. So I believe there's already been an arrangement which is temporary of additional 6 midwives being appointed, which is probably intending to deal with the expected increase in activity, well, from next month, I suspect. But I think we know there's still some more work to do on all the various actions that we might need to take to deal with the capacity and ensure the safety.
Thank you, David. And David, both you and I are non-executive directors, safety champions for the maternity services. And I think we're both of the shared view that we are incredibly proud of our maternity teams.
Yeah.
And as evidenced by how many women choose to come to Warwick to have their babies, our reputation is phenomenal. But we do need to make sure we don't become, if you like, victims of our own success. And that our primary concern is the safe delivery of healthy babies and the well-being of mums. And then on the integrated performance report, Fiona, to include data on intelligence conveyancing in future reports, that's in progress. We do talk about that a reasonable amount, but Fiona, any update on that?
Yes, we had our first sent through from West Midlands Ambulance this week, which will now be sent on a monthly basis, and it'll form part of Harcomal's part of the integrated dashboard, because it probably sits more clearly there when Harcomal describes A&E pressures.
Okay, thank you very much, Fiona. And Glenn?
Just on that, Fiona, I just wonder whether we're able to just take a little bit of a look at how that compares to conveyancing elsewhere in the region. And maybe it's a separate conversation we can have, but it just feels like we ought to understand whether it's happening to us more often than it is to others.
Yes. Okay, let me take that offline. I think that comparison was available, so yeah, okay.
And I think we do think it happens more to us, Glenn, than others, don't we? But always be evidence-based. Okay, any matters arising that colleagues feel I've missed, please raise a digital hand. So I think we're then on to the foundation group minutes of the last meeting. And I would really encourage members of the public to come along to that. We had a very interesting meeting in May, and those board meetings are where we tend to do more comparisons on particular performance metrics and quality and safety metrics. If there are any points of accuracy on those minutes, could you please raise a digital hand for me? Okay, and then the matters arising will be handled in the next full board meeting, which is coming up in a couple of months. So we'll move on then, and just in terms of the board workshop for members of the public this morning, it was a pretty eclectic mix. As I mentioned, we talked about workforce productivity, we talked about our work as a community integrator and the really great leading work we do in that regard. We talked about population health management, so a whole variety of different things were covered, and a real focus on driving productivity, which is our primary challenge this year. And at its simplest, our challenge in terms of delivering what we need to this year can be summarised in two simple mantras. Drive elective activity as hard as we can, and minimise the use of expensive temporary workforce. If we do those two things, we'll serve our patients well and we'll serve our taxpayer as well. I think we therefore move on to items for approval, and the first is the all-important but always accepted approval for our going concern status. Kim.
No, thank you, Russell. So this is our annual declaration to confirm that we will continue to provide NHS services, and therefore see no objection for us to continue to make the declaration that we are on our going concern, and this has been approved by our audit committee.
Super, thank you. And Kim, just for clarification, it would be catastrophic if we weren't able to declare ourselves as a going concern, wouldn't it? This is for approval, so any questions on our going concern status? That's a relief. If you're not happy to approve, please raise a digital hand. That's even more of a relief. So we'll move on then to our final annual financial plan. This has taken, I think it's fair to say, Kim, much longer, nothing to do with you and the hard work of the SWFT accounting team and finance team, but this has taken a lot longer than would ordinarily be the case. But where have we ended up, Kim?
Yes, so after much negotiation, so you recall the last board meeting, I brought a paper that was still a draft that presented a draft plan, a deficit of about £12.5 million. Further negotiations took place with the ICB, and we eventually got to a place where we can submit a break-even plan. We received further funding from the ICB, albeit some of it non-recurrent, and we also did a further stretch internally as well, and that's how we've arrived at a break-even plan. It's not without risk, which I've highlighted in the paper already, and I've also included a paragraph there to say things are still changing. So I'm sure Glenn will make further reference to that in his update later on. But we received a further letter on Friday about the fact that they are releasing nationally limits to ICBs in terms of the size of potential deficits. We received our letter as an ICB on Friday, and there have been ongoing discussions with our ICB and system colleagues. We remain as a system having a deficit. It's bigger than what I've referred to in the paper, because some of the assumptions that were made at that time didn't quite come to fruition. So we're still looking at a deficit of about £35 million as a system, mainly driven by one provider. So that's where we are. So discussions are still ongoing as to what that means for us.
Yeah, I think it's worthwhile, just before I invite questions and perspectives. I'm also pleased that the George Eliot's financial plan is for a break-even plan, and as I understand it, Coventry and Warwickshire Partnership Trust are also at break-even. Questions and perspectives on Kim's recommendation, Glenn?
Yeah, I was going to talk about the wider system position a little bit later in my Chief Exec's report, but I think In terms of our internal plan, I mean, regardless of what happens at system level, I think it's really important that we absolutely nail down that internal plan and ensure delivery through budget holders and divisional teams. So Kim's been working on that in the background also. So I think, I think being clear about the expectation inside the organisation is something that hopefully we can clarify by signing off this plan now.
No, great. Thank you, Glenn. Any questions or perspectives? We've obviously involved numerous times as a board as we've continued to try and improve our numbers. Any questions or perspectives from colleagues? If you're therefore not happy to approve, could you please raise a digital hand? Okay, duly approved. Thank you very much. So we then move on to the annual review of key performance indicators, including the quality indicators. Harkamel and Fiona, over to you.
I'll take this one. So the operational planning guidance was released on the 27th of March, and that's quite a bit later than it usually is, and that's why we've had a bit of a delay in terms of getting it to board. The ask in the guidance does remain on quality and safety, as well as a real drive to improve waiting times, and the report outlines some of those requirements that are set out as part of the guidance. So I'm asking for approval of these measures, and then they will be incorporated into our performance measures, and that all of our integrated performance reports. It will also be mirrored across the foundation group, so there will be consistency.
No, fantastic. Any questions or perspectives to Harkamel or Fiona on the quality side? Again, colleagues who've been involved in this journey, if therefore you're not happy to approve, could you please raise a digital hand? Members of the public may sometimes wonder how we're able to march through this quite quickly. It is because in previous board workshops, we've had presentations and have worked on all of this work that comes forward for approval. We'll therefore move on to the annual review of Clinical Governance Committee and Management Board terms of reference. Sarah?
Thank you. So the board will remember that the majority of board committee terms of reference were considered at the Foundation Group Board's meeting last month. They were considered and approved. Further work was required on the Clinical Governance Committee terms of reference together with the Management Board terms of reference. So they're here today for the board's approval, please.
No, thank you. And the changes have been marked up as well. Thank you, Sarah. Any questions or perspectives on these? Again, if you're not happy to approve, could you please raise a digital hand? Okay, duly approved, thank you. And then we're on to the annual review of standing financial instructions and scheme of delegation, a full 79 pages. Thank you, Kim. Kim, over to you.
Thank you. So we do the annual review with a team of appropriate people, and we've taken the changes which are highlighted in the executive summary through to audit committee. I think it's fair to say that we are constantly reviewing those controls, so we may have to bring a further set of to board for approval as we, review our internal controls to ensure really that we reflect any sort of system controls or tighter controls that we wish to impose on our organisation to ensure that we hit our financial plan. So just wanted to flag that to the board, but otherwise these have been approved by our audit committee.
Thank you, and the changes are highlighted as well. Any questions or perspectives from colleagues? And again, if you're not happy to approve, could you please raise a digital hand? Okay, duly approved. So if people are following the pack, we're on page 137 of the pack, and we are at the Chief Executive's report. So Glenn, there's an awful lot going on. I would just remind the board are obviously aware, but members of the public, we are in a pre-election period, so we are in a period of purdah, which does affect some of our decisions, but certainly I will make sure that our debate is entirely appropriate given the pre-election period that we're in, as it would always be anyway. But Glenn, over to you.
Thank you, Chairman. Feels like you've cautioned me to be careful what I say at this point. Now I'll start with something really positive, which is the Foundation Group Improvement Week. which I know a number of non-execs were able to dip in and out of too. It was a virtual conference across the group, and it's the second time we've held this conference, but this time with our Worcestershire Acute colleagues joining us as well. So you can see the numbers there, 1,868 people joined in. And it was great, and it's kind of what we're about actually as a group, that we share best practice between the 4 trusts within the group. We also had some visitors from outside the group and opened it up to some of our system partners as well, so a real success. So just like to formally recognise the efforts of the improvement teams across the group. We don't have many of them deliberately, because improvement is everyone's business, but they pulled this together and it was a real success. So they'll be doing it all again next year. I then talk about financial escalation meetings. Obviously, we just touched on this with Kim's plan paper. We had a face-to-face meeting as a system on the 10th of May with NHS England Chief Exec and colleagues. And it was made very clear to us there that there is a need for the plans across the NHS to improve, and depending on what numbers you believe, there's a circa £3 billion gap at the moment between where those plans need to be and where they are at the moment. As Chairman just mentioned, we had the George Eliot board yesterday, and I'm pleased to say George Eliot have now moved to a break-even plan also. But our overall system plan is still in deficit, which, as we sit here today, is not has not been accepted by NHS England. University Hospitals Coventry and Warwickshire have a challenge because they are implementing their electronic patient record, and that's led to a planned lower level of elective activity, which affects their income. So there are conversations going on about that. My biggest concern here is the current national stance is that if a system is in deficit, then all parts of that system go into some sort of financial special measures exercise, which I think would be unnecessary for us, and potentially would be distracting, because it would involve many people on this call and others in the organisation having to explain, justify, go through individual transactions with system colleagues, and that will take us away potentially from delivering what is quite an ambitious cost improvement plan, as Kim set out in the paper. So I want all of our people focused on the improvements rather than the justification of how we're going to manage the organisation, as we will be managing the organisation within our budget and not going into deficit. And I like to think we've got probably the best track record in the NHS of doing that over the last 15 years or so, of not being in deficit. So those conversations will continue, and I'll be very keen to ensure that we keep focused on what we need to do as an organisation, but also to work with system partners to help to improve efficiency of the system. Which takes me nicely on to workforce productivity diagnostic tool, and Kim took us through this and some other productivity measures earlier today in workshop. We are going to take a bit of a look to see whether we can potentially add this into our dashboard in some shape or form, because this particular tool is that there will be a heavy focus on it throughout this year. And what it shows overall is that the NHS, when you compare today with the pre-COVID year, the 1920 year, has seen an overall reduction in productivity of around 11% based on this methodology of measurement. And you could maybe challenge whether it's the best method, but it's a useful one. It looks at how many extra staff we've employed compared to the extra activity that we've delivered. What it shows for us, though, is a pretty positive story. You can see there workforce growth of 12.4% over that period, but an activity increase of 22.7%. And some of that workforce growth was not about activity. If you look at areas like maternity, where we've increased the number of midwives to improve quality and safety, and that wasn't about activity. So that overall computation of 9.2% implied productivity gain is a good place to be, but we're not complacent, and our plans for this year will look at the two aspects of that. One is doing more elective work, taking patients off the waiting list and therefore securing additional income and therefore productivity gain from that. And then secondly, reducing temporary premium labour costs, so reducing agency spend. I won't talk about capital incentives for A&E, but there's another period of that, and I'll just talk a little bit about agency spend. We did a piece with the BBC highlighting the Thornbury agency, but there's other agencies that we could mention that are particularly expensive, that charge the NHS a lot, but also that don't necessarily pass all of that on to the individual clinicians. So we would very much want to convert that kind of expenditure into directly engaging staff ourselves, and obviously employing staff who will understand our local procedures and pathways. So across the NHS from July, we will be trying to hold a line of saying we will not use these off-framework agencies. We'll only use the agencies that are prepared to operate within that framework ceiling cost. And that's something that we're gearing ourselves up to be able to do. I then referenced the Century Garden groundbreaking, which was great to see, and the work is started on that alongside Malin's Ward at the moment. Really appreciative of the donation from the individual who supported that garden, and we'll talk more, Alan Jackson, about that when it opens. There's then an update from the ICB. There's that Going the Extra Mile Award winners. A little bit of a focus here on our North community teams and some of the work that they're doing. They're particularly well integrated now with colleagues at George Eliot and helping to improve discharge pathways, and you can see some of the work is referenced there. And then the usual list of planned visits to wards and departments from execs and non-execs, just to emphasise this isn't about, these aren't all the visits that go on, because there's lots of ad hoc visits that go on with exec directors, but these are ones that non-execs are joining and providing an opportunity to talk to teams and listen to some of the issues and opportunities. So I'm happy to take any questions on any of that.
Thank you very much, Glenn, and thank you for your work behind the scenes with national colleagues on a whole variety of issues. Any questions or perspectives to Glenn? What's worrying you most at the moment, Glenn?
I think that the financial pressures that the NHS is facing are certainly the top of my list at the moment, and you know, the fact that we're in June and we haven't nailed down the plan, which is unusual, and that's obviously not allowing everyone in the NHS to focus on the delivery. I like to think we are focusing on the delivery because we've got a plan that's in balance, but I worry about that, and it's not be easy for us to pull this off this year. We'll no doubt have another challenging winter, so that's probably the big conundrum at the moment, how we manage that.
Okay, thank you, Glenn. Okay, Tim, we'll move on then to the integrated performance report. Started off the year with being very, very busy, Adam, and thank you to everyone on the front line for their phenomenal work. We'll no doubt touch on the ED numbers. Adam, over to you.
Thank you. Yes, we have been phenomenally busy, as you say, Russell. We would normally expect some respite in April from the winter demand that we see, but that certainly wasn't the case this year. And in fact, April and on into May had some of the busiest days we've ever seen for urgent care demand, and considerably higher than the same period last year. And you can see some of the details of that in the Chief Operating Officer's report. We've seen a similar picture across our services, certainly with cancer 2-week wait referrals. We are seeing a sustained increase there, and that is having an impact on our cancer targets and is one of our areas of concern at the moment. And we have put some additional intervention in there and continue to work with partners across the system to drive improvement in that area. I think another area of concern we touched on earlier is the increase in complexity in our maternity services. So particularly with the number of caesarean births that we are seeing, and that those births are clearly more complex for our maternity services to deal with, and are having a real impact on capacity, which have led us to rethinking some of the scheduling in those services and putting additional sessions on at weekends to account for that demand. I think while we've been very busy, we have seen a slight drop in our emergency department performance, and we're not where we want to be, but we are still among the best trusts nationally, and I think that paints a picture across the NHS really of the sustained level of demand that we've seen across the next couple of months. We have managed our demand by keeping a number of our winter schemes alive. So the winter schemes we put in place that have the highest effect really on performance and meeting demand, we've kept in place. But some of that is not sustainable because clearly that costs us. And we've heard about some of the challenges with finances this year. While we are very busy, a focus on quality is more important than ever, and the Chief Medical Officer and Chief Nursing Officer's report looks at some of those specific areas. The one we've touched on that we are really focused on is the reduction in temporary staffing spend, agency staffing spend, because we know there is significant evidence that having substantive staff working on wards who know those wards and know our patients really improves and drives the quality of our services. And there is more work for us to do there, but I do want to just take the opportunity to celebrate some of the successes there. So our agency staffing spend in April 2024 was £750,000 less than April 2023, and I think that's testament to the work of our nursing and operational teams across the work. But that's not to say we're resting on our laurels. This remains an important work stream this year, and there is more to do, and we are aiming to meet the national target for none of the high cost tier 4 agency spend by July. The Chief Finance Officer will talk about the financial position, and we've already touched on the really challenging cost and productivity improvement programme we have this year, which divisions are managing. We were slightly off track in month 1 on delivery of that, but we would expect that as schemes are set and settled. So I don't think there's a particular concern there yet, but it is a really tough programme to deliver. Glenn and Russell have touched on the board workshop session we had this morning to talk about our workforce productivity, and productivity is a big area of focus this year, which we're driving through our Excel in Everything programme. That's all I was going to summarise, but I will hand over to my executive comments for their reports.
No, thank you, Adam. Great summary. And Charles and Fiona, anything you'd like to add to Adam's sort of overview on the quality and safety side?
Yeah, just I think just a summary really, because from a quality point of view, I'm really proud that our quality remains high despite the demand that Adam has and Harkamal will discuss in a moment in terms of patients we're seeing, but the care in terms of outcome, so mortality, but also complaints and patient feedback remains good. I think the rollout of PSERF, and for the public, that's a replacement to the serious incident framework nationally. It's a patient safety incident framework, has allowed us to free up clinical time to investigate the incidents that do still happen, that we don't understand or that are unusual in their nature, and not investigate absolutely every patient that develops a pressure ulcer, because generally we know what causes those. And so that has allowed us to not only spend our time investigating the new and unusual things, but also to spend the time on implementing improvements. And you'll see from the data in my report that the falls incidents particularly are going down. they've never been high, but actually they were stuck at a fairly consistent level, and they are going down now. And I think that's because we're having really good conversations at ward and team level with staff to say, what is it that caused that? You know, what part of the process failed you and stopped you being able to give the best care. The busyness of our services is a concern, as I've said, and just balancing the risk of seeing all the patients that want to be seen, and that is an important thing. They do want to come here because we are good, but being able to give safe, high quality care to all those patients is a balance of risk. I'd say the areas that I'm worried about is the demand in maternity, as we've already said, is some of our elective lists and the demand in those, and particularly the diagnostic increase, and seeing those patients as they would expect us to be to see them. And then just individual patient risk is communication, particularly on discharge and transfer, and how that can, if people aren't given empowered really just to pause and make sure that it's safe whilst trying to manage demand, then that can create a risk. And you know, I think I would encourage all of us to focus on that being an area of improvement continuing.
Thank you, Fiona. Charles, anything you'd like to add to Fiona's comments on mortality?
Well, we've got the 6 months report on learning from deaths coming up, so we cover mortality then, I think. Okay, but great. Nothing else to add.
Any questions to Fiona or Charles on quality and safety? As you say, Fiona, we cannot afford to be complacent on quality and safety, but it is, I think, quite remarkable. We talked about infection prevention and control this morning as an example on safety, that despite this enormous increase in demand on our services, we are still getting forward in momentum. So very well done. Please I know we've got Ellie Ward on the call today, but please thank all of your team for their hard work. We'll move on then to the operational side, the engine of the acute. Harkamel, over to you.
Thank you. So I was going to start off by saying April was our busiest month ever in terms of A&E activity by volume overall, and also the average of daily attends, but then May happened. So next month, I will say May is the busiest month that we have ever had in terms of activity through A&E. But this report is about April. So as Adam alluded to, we achieved a performance of 75% against our 4-hour standard, which was a drop when you compare us to March. And some of that was, I talked before about the drive to end the year, you know, as far above 78% into the 80s as we could. And in Glenn's report, he has referenced the fact that we were successful in getting access to some of the capital schemes, because we were able to demonstrate top performance in the country, as well as most improved between January and March. One of only 2 organisations in the country to do that, so I'm incredibly proud of that. In terms of April, as I started off by saying, we were incredibly busy, and the volume affected our compliance against that standard, as well as having to step down some of those schemes that we had in place as winter funding came to an end. We have kept quite a lot of those schemes in place because, you know, as Fiona's just alluded to, quality and safety is absolutely our priority, but trying to balance all of those things is incredibly challenging. Of concern is our admissions to surgical specialties. We've not seen this level of surgical emergency demand ever. And what I used to be able to say is that actually our bed base is right for surgery. What we've seen over the last couple of months is that we have been running out of surgical emergency beds, which has been concerning. But where the organisation's really pulled through is that admission avoidance work that we do. So the same day emergency care is absolutely vital. You know, working with our primary care colleagues, making sure that we're putting out messages to remind people of pharmacy first, and doing some of that signposting remains really, really important for us. We also do a lot of work around patients who use our services more often, so our higher intensity users, to be able to try and catch those and point people in the right direction. So for our most poorly, so our type 1 activity, we dropped down from 5th to 9th, but we are at least for our most poorly patients still in the top 10. From an elective perspective, I'm really proud to say that we got off to a really good start from an elective activity perspective. And given what I've just said around the surgical emergency work, that's more patients coming through A&E who then require access to theatres alongside all of the planned work that we've got going through theatres. So the fact that we managed to perform well when you compare us to our baseline activity, I think is really, really impressive. Our diagnostic performances also continue to improve, driven by the improvements in non-obstetric ultrasound. That said, I'm still quite worried about it. And I'm also worried about audiology. Both have improvement plans in place, and we are seeing improvements, but I've kept them on my report so that everyone is cited to it. And in terms of our longest waiting patients, we've done really well on elective recovery, and we have a really strong plan in place to get below 65 weeks before the end of the summer. It will be sooner than that. And we are, we've got our sights set on getting below 40 weeks. The only exception to that is orthodontics, and I've spoken about that previously, so I won't sort of labour the point, but it's just to assure the public that we are still working with NHS England and our ICB colleagues to do as much as we can to bring down those weights. Cancer performance, as Adam alluded to, was really worrying for March. So we did just miss the 28-day faster diagnosis standard. And when we look forward to April, our performance dipped again. That said, looking forward to May, we have managed to improve our position. So we have enhanced our approach to governance around that. So we've got a lot more scrutiny of every single patient on that on the waiting list, and have got lots of clinical engagement in trying to improve those pathways. So although March and April are concerning, May does show signs of improving. And then the out-of-hospital performance remains strong, and we managed to increase our 2-hour urgent care response to 89.9. Still a little bit worried about our 28-day length of stay in our community hospitals, and we keep an eye on that. I have included a bit of a deep dive from an operational perspective on maternity. So I won't talk about it too much because I know we're onto this later in the agenda. But it was just to sort of set out for everybody that we have seen an increase in registered births since 2018, and that doesn't mirror the national picture. It doesn't mirror the local picture. So it is really interesting, I think, to see what's happening here. And we have had 3 consecutive months where we had births over 300. That's significant for us. And we've had a sustained increase in births from mothers out of area. And when we look at where our babies have been born, we've seen an increase in our babies born in our Bluebell Birth Centre, which is really impressive. We've talked a lot about some of the concerns in maternity, and we'll come on to that later. But just to assure people, we are cited on what the risks are. We have an increase in complexity. We have high numbers of, or an increase in emergency and elective caesarean section. So obviously that increases the demand on theatre capacity. And the pressure certainly is being felt. So I just wanted to include our actions that we're taking. So we do know when we're anticipating peaks in demand. So we births are booked in, and you can sort of see when we are going to get busier. And we've proactively planned additional caesarean lists. We've increased some of the staffing. There's an MDT in place. There's daily escalation, and there's quite a lot of oversight from an executive level. So that's just for assurance from an operational, like the practical, what are we doing about some of this demand that I've included in here. Me? You're on mute, so.
Questions and perspectives to Harkamel. Glenn?
Yeah, I mean, just picking up on your analysis there on the number of births. It's encouraging to see that our midwife to birth ratio remains 1 to 25, though, because we set ourselves, what I think a couple of years ago was a challenging target of being beneath 1 to 27, and we've remained below that during this year. And I think when I look at other organisations, I think I'm seeing ratios that are above 30. So I think that's a positive. It doesn't take account of case mix, but I think that's a positive indicator of the ability to control the numbers.
Yeah, no, thanks, Glenn. And Sue Whelan-Tracy?
Yeah, hi, Harkamel. I'm aware that occasionally 111 goes down and everyone gets told to go to A&E. Do you receive figures on that? And is that something that happens frequently enough that we ought to see it?
I have been asking for figures on that because it happens frequently enough that we notice. And it's not necessarily when 111 goes down, it's when other organisations, it's happened when Leicester have been busy, or the Black Country, and then those patients are advised to come to us. So there's a bit of that. There's also quite a lot of patient choice. Reputationally, patients have elected to travel past 5 or 6 hospitals to come to Warwick. We did do a piece of work, helpfully led by our governors, who did a bit of an audit in terms of asking all the patients in A&E why they chose to come here and where they've come from. But the point around 111 is a good one, and I have been pushing for that data, and I'll carry on trying. If I get it, I'll include it in the pack.
Okay, thank you. And any other questions, Harkmel? Sorry to do this, Harkmel. I apologise for the fact I didn't mention it before. But in terms of the birthing numbers, I can't quite work out how if 46.4% of babies are vaginal births, 21% are emergency caesarean, and 26% are caesarean section, where the other babies are coming out. So I think we're missing 6.8% of babies. So if we can just watch the maths on that.
I will find the babies and I will put them in.
Thank you.
They might be instrumental deliveries, mightn't they, which don't appear in either necessarily.
I'll make that clearer though. Thank you. Thank you, David.
They are, I asked the same question. Okay,
so, but just on a more serious point, those caesarean numbers are very, very high. And far be it for a man to say this, but certainly there are consequences for babies' gut flora if it's an elective C-section, and there's a developing body of evidence that vaginal births, if it's safe, is by far the best thing for babies' long-term health. And I'll just leave that, recognising the problems of a man saying that and never having had a baby. We'll move on then to workforce and Gertie.
Thank you, Chair. Mindful of time, so I'll try and just pull out some key points. Recruitment continues its positive progress, particularly around the innovations in terms of streamlining recruitment. We've said a couple of times already today on board that the best option for us is to have our own substantive staff. It reduces expensive agency, and it provides an improved quality of care. I include with that our bank. The bank is a very important part of our workforce, and we can see improvements both in substantive and in bank. Particularly pull out the time to hire, which is now sitting at about 2.3 days. And I think I'll ask the team to include a summary in next month's board round where we have been and how we progress, because it's not easy to pull out in the report. In terms of areas of concern, there's some bespoke campaigns really focusing on some of our harder to recruit into, and we do continue working with apprenticeships as well in terms of what we're doing. Sickness continues in a downward trend, but it is still above the trust target. It is improving, and we've developed some additional targeted interventions and targeted support, particularly based on some very helpful feedback from Harkmel and our ops colleagues in terms of how we give them the sort of the best level of support we can in terms of supporting our colleagues who are off. Appraisal has now moved into a point where it's above the trust target. I am still concerned because it's only just slightly above target, and I'm consciously aware from the feedback through our finance and performance where we monitor this, that one of the issues that really does get in the way is the difficulty of recording those appraisals. We will be launching a new learning platform in June into July, and that should make recording appraisals and accessing training much more easy. So I would hope that in future months that we see the appraisal compliance stay above 85 and in fact go beyond that. I think that's all I'll pull out, Chair, but they have to take any questions. You're on mute, Russell.
It's been a real source of encouragement, performance on recruitment and international recruitment, and I know this is your penultimate board with us, so we'll thank you more fulsomely next time, but it's a testimony to your impact with us. Any questions or perspectives to Gertie? Okay, so Kim, we sort of touched on the numbers a little bit. It's still early, we're flatlining the CPIP numbers, I believe. But anything you'd like to pull out on the month 1 results?
Okay, thank you. As you said, we've flatlined the CIP profile, which is, you know, I wouldn't say inconsistent, but everybody does it slightly different. So some organisation back end their profile of CPIP, but I think the key thing is that can distort this position and also give people and organisations a false sense of security, I think, around what their plans are and their delivery. So we have flatlined our target. That said, we are off plan with £2.5 million in deficit in the first month. It's not unusual, you know, month 1 is always a strange month, but we are working up our cost improvement programme. In the report, I've identified £8 million, just under £8 million of the cost improvement programme, but behind the scenes we've been working to put numbers and values really to the schemes that we are already working up, and that there's a further 8 million on top of that. So we're looking really you know, around sort of 8 million, less than that. So we're looking around about probably 12.5 already that we've got values against. And we've also got about 4 million of cost avoidance and productivity schemes, because, you know, I think it's really important to be able to capture those. On top of that, you know, we're obviously got I say ambitious, but, you know, I think a challenging reduction around our agency spend, as we've discussed as well. And we've also got plans in place to, as I said, stop the use of framework agencies. Just actually had an email from the national team to say that they're really pleased that already, you know, they've seen a reduction in the use of off-framework agency, and that's really positive news, really. So the work that the teams are doing already, we're seeing that reduction. So that's really positive news as well. In terms of the drive, we're focusing on devolve accountability, you know, giving obviously that making sure that the budget holders are clear around their budgets, because that's the way we hold our organisation to account. To give a bit more support, I've introduced more monthly run rate reviews with myself to focus on areas that may need a little bit more support or clarity, in order to make sure that we finish things off and be really clear as to what rectification or mitigations that we need to be putting in place early on. So the focus is really around driving the reduction of the run rate. That said, we have got some challenges. We've touched upon there are some risks within our plan, and we've also talked about the fact that we are continuing to spend it in some areas as a result of the continuation of winter pressures and the operational pressures that we're experiencing. As ever, you know, we as an organisation and executive team work hand in hand together in terms of the management and the balance of the risks that we hold together. I think those are the key things that I just wanted to highlight, Russell. Thank you.
Thank you very much, Kim. Any questions or perspectives to Kim? It's still early doors, but that reduction on expensive temporary agency usage, which Adam referred to in his summary, I think is pleasing, as well as the way we're driving ERF, Electric Recovery Fund. Okay, team, we'll move on then, and a series of reports to receive. The first is the quarterly safe staffing report. Fiona, what would you like to pull out of this?
Yeah, thank you. So this is the quarterly staffing report. It looks different this time, and thanks to Ellie for pulling it together. It's a much more condensed picture that just really focuses on what you need to know, which is the risks and challenges, but also the good news. In that vein, I think the good news is the reduction in agency, which we've referenced a number of times here, driven not only by the detailed work that the matrons and ACNOs doing at the ward and department level, but also the recruitment that Gertie's just mentioned. Particularly, I'd like to thank the support that has been provided by the recruitment team into the paediatric ward and into pharmacy. There's been real improvement in their vacancy position, so thank you, Gertie, to your team for the help there. Maternity is also in a good place, has no vacancies there, so really helpful for the demand that we've reflected there. The challenges, I suppose, is that ask or demand that we need to implement and stopping off framework agencies. There are some risks to that, but we are pushing our teams very hard to be creative and find solutions around that. We only use off framework agencies in certain areas, and they are identifying the risk related to that and any alternative actions and plans that they need to do to meet that deadline. Other challenges for agency spend and usage of additional staff is the increase in mental health patients and the complexity that brings in terms of the need for additional staffing. And some of our smaller AHP teams, that's reflected in the report. You'll have seen that, for instance, speech and language therapy and podiatry are really challenged because they're very small teams, and nationally the recruitment is a challenge. So I'm happy to take any questions, but hope you like the format of the report, but I'm happy to take any feedback on that.
No, thank you, Fiona, and thank you, Ellie, for your hard work behind the scenes on the report. Any questions or perspectives to Fiona? Okay, we'll move on then to the perinatal quarterly report. Lynn, thank you for joining us. Lynn, over to you.
Hi, thank you, everyone. So the perinatal quarterly report, you may notice this is a new title and a slightly different format. This is part of our work that we're doing to streamline our maternity reports across the foundation group, but also to bring us in line with regional and national reports. So this is Q4, so going back to January, February, March. Some of the data is reflective of April, but that is referenced to within the report. So our service has been busy focusing on keeping our service safe, despite all the things we've been hearing at Trust Board today about our increasing demand and challenges with capacity and increasing complexity. At the end of April 24, we'd reached 3,308 births in the financial year. So this is the biggest we've seen. As it's been talked about, we are doing loads of work in the background. We've done a deep dive into our maternity and neonatal services, and we're working really closely with the board and with our specialities, because maternity affects lots of different specialities, developing the intermediate, interim and long-term plans for maternity. As Fiona alluded, we did really well and we achieved a 0% vacancy rate for midwives, and in the current climate that is something that we're really proud of, and also for our maternity support workers. However, an ever-changing picture with recruitment. So in May, we found ourselves with a small vacancy, but we've managed to quickly recruit again, and we're back to 0% vacancy, which we're again really proud of. We still do have some concerns around our appropriate substantive theatre staffing, and this is to do with making sure we have the appropriate skilled staff who can scrub for our theatre activity and the recovery of our women, and also the use of agency. Obviously that comes at a huge cost, and the confidence now of midwives who are scrubbing less, but this is quite a new risk for our service. But transferring our obstetric theatres over to theatre services is included in all the plans that we are looking at and working on really hard. In Q4, we remained green for our key data and targets, but we did flagged red for some sickness in both maternity and neonates, and we're working closely with our HR colleagues to drive that down. Training compliance just slightly dipped in Q4, just around the safeguarding, but that's all now being resolved. Work is ongoing for our Year 6 maternity incentive scheme after being successful, being compliant for Year 5, which was really good news, and we are on track, hopefully, to be able to be compliant again. 13 out of the 15 safety actions in our Ockenden work are now completed. Our Saving Babies' Lives version 3 work is also progressing really well, as well as the 4 themes as part of the single delivery plan. We've currently got no active cases being investigated by the maternity and national safety investigations, and our perinatal deaths are below the national average at the moment. The dashboard in the report shows the March data with our lowest number of births for a while, even though we're still reporting the highest number of births the service has ever seen annually. Noted, though, is our increase in inductions, and this is recognised nationally, but we can't really see any particular trends, and our postpartum hemorrhage rates, as we've often talked about in our updates, have varied through the quarter, and we're still doing all the work we can to keep that as low as we can. Our triage delays remain really low, and the number of babies that are readmitted are within expected levels, but we don't stop reviewing and auditing all those cases. Training and IPR rates are really good, and we're working on, as you can see in the report, many quality improvement projects, and we don't stop looking forward. The maternity workforce tool that was completed in the last 2 quarters, that's the Birth Rate Plus tool, was received. We had the draft at the end of April, and we got the final draft towards the end of May. The Birth Rate Plus recommendation overall was a total of 132.61 whole-time equivalents. The required increase is reflective in the changes in the increased complexity and number of women that we care for in our service. And due to the evidence presented during our immediate safety plans as part of the deep dive into maternity, we were funded with 6 full-time equivalent midwives, which have already been recruited into, which is really good news. So a busy quarter again for our service, and actually this was recently acknowledged when the Chief Midwifery Officer for England, Kate Brintworth, came to visit. It was last week, so not in the quarter, but I wanted to mention it. She commented that she couldn't believe that we could deliver a service so well and that was so busy on the footprint that we have. And just to quote her, she said, "South Warwickshire may be on a tiny footprint, but it has a lot of heart." And she thanked our team for having such an interesting, open conversation about continuity of care. And she said that she was really pleased that we were able to share and explore our opinions to move forward in a positive way. And she learnt a lot from her visit. So I just wanted to share that with the board. Happy to take any questions.
That's great, Lynn. And, with you, Lorraine, Becky and Jelly, we've got a super team and we're very lucky to have you. Any questions or perspectives to Lynn? Glenn?
Yeah, I saw that feedback from the chief midwife, which was great, actually. Surprised that she was surprised that midwives would be willing to share their opinions there. But there you go. Just one thing to pick up on page 182, when we talk about current position, it refers to Q4 of 24-25. Obviously, it's Q4 of 23-24. But the neonatal mortality indicator, it's good to see where that is, but have the region now updated their data, because they seem to be using data that's rather old?
Yeah, no, the data never quite correlates, unfortunately, so they are still using older data. And I'll correct the date, so sorry about that.
No, thanks, and that's irritating. Ollie?
Yeah, I mean, I can see lots of change and lots of good results, but in light of all the change and the sickness we heard in the previous report, how's the team morale going then?
Well, our survey results were really positive. It's really difficult sometimes. The team morale overall is really positive. Our team love working with us, but we do have some really challenging days and we have some really challenging cases, so that obviously does have a real impact. A lot of our staff, like in every other department, also have a lot of things going on out of work, so to reassure you around the sickness, a lot of it is unfortunately some long-term sick of some serious medical conditions, and very few to do with work-related absences. But we are doing everything that we can to reduce those sickness levels.
No, thanks. And Fiona, do you want to add something? Then we'll move on because we.
Yeah, just very briefly, Ollie. I think you're right to question that because morale is affected by busyness, but we've got a waiting list of midwives that want to come and work here. That's why we only agreed the management board uplift a couple of weeks ago, and we've already recruited to them. So I'm not worried about morale, although Lynn, is right to say that the pressure on certain days is significant, but she's got a great team of retention, well-being midwives that really support them to talk through those cases.
And I think just to further level of assurance, David, you and I, Fiona, have private sessions with midwives when we do our safety champion walkabout. So, and as Lynn sort of indicated, if it's been a bad day, an incredibly busy weekend or whatever, the team understandably are feeling a bit exhausted, but generally the motivation and enthusiasm is very high. Lynn, thank you. Angeli, thank you for joining us. Please pass on our thanks to everyone. We'll move on a few minutes behind, guys. So we are therefore on to the patient experience annual report. Fiona, what would you care to pull out of this?
Yeah, so this is an annual report, so it is accumulation of the quarters that you've already seen, so shouldn't be any surprises. Good news is complaints remain low compared to our demand, our patient demand. 90% of our feedback is very positive. We've made improvements with PALS, bereavement translation services. Big shout out to volunteers. There's a big section in my report. Hope people have noted that our volunteers are exceptional. But the next year we're going to grow that even more. Sort of thinking about the challenges and the plans for next year. One challenge and one thing that we need to continue to improve is the response rate for formal complaints. When we don't have many, when we do respond, we respond well. We've only had one that's been upheld by an ombudsman in the whole year, which is a very good outcome. But actually, we don't always respond to them in a timely manner. So we need to improve that. But next year is all about growing and increasing our volunteer services and coordinating and analysing our patient experience and public engagement data at a much more sophisticated level. So they're the two things that you'll be seeing in the next year's reports.
Yeah, no, fantastic. And I'd just like to reinforce Fiona's comments about our volunteers. We are very lucky to have as many volunteers as we do. I know some of you are on the line today. Thank you very much for your continued endeavours to help us be even better than otherwise we would. Any questions to Fiona? So thank you, Fiona. And we're therefore on to the Improvement Board quarterly update. Glenn, what would you care to pull out of this?
Yeah, thank you, Chairman. So I think it's helpful for the board to see this on a quarterly basis because it helps to demonstrate our single approach to improvement, which is about quality improvement, cost improvement, productivity improvement, all through a single approach. And we train as many staff as we possibly can in the QSA methodology of service improvement. So what the Improvement Board's role is to firstly ensure that we are building capability across all of our staff and we make it everyone's business to focus on improvement. But then secondly, how we're using that capacity. And then thirdly, a responsibility to do some post-investment analysis to ensure that we've received return on investment of business cases, particularly the material ones that have gone through board. So you can see a summary there of the last 3 meetings of the Improvement Board and some really good examples of improvements that have been made, some work to assess ourselves against the national approach to improvement. And then we referenced earlier things like selling everything, which is our approach to cost and productivity improvement. It's also really good to see the Worcestershire Acute team come along to the improvement board and share with us some of the work they've been doing on single point of access. And we do encourage that cross-fertilisation between the improvement boards across the group. So I'm happy to take any questions on any of this, Chairman.
No, great, Glenn. And like you said, the Improvement Week programme that we had was wonderful. Any questions to Glenn on the Improvement Board quarterly update? Okay, thank you. So, Charles, the 6 monthly update on our performance and learning from deaths.
Okay, so as you can see from the report, our mortality indicators remain in control limits. As is usual, there are various subspecialties, sub areas that trigger for further investigation, and we've done several deep dives into those. In particular, one that had gone up significantly was sepsis. And you have to remember that this is not what the patient actually died of. It was the diagnosis that was recorded on admission. Basker, myself and Janie Anderson have actually reviewed some of these cases and found actually no concerns with the care and very good quality of care, which was reassuring. The other good news is that the IT system that we've had some time getting going to monitor the mortality reviews and mortality dashboard is now in place, and our medical examiner model is taking on all the deaths, including in primary care. So that's all I want to say, but obviously if there are any questions, I'm happy to answer them.
Thank you very much. Any questions or perspectives to Charles? Okay, thank you, Charles. So we'll move on then to the report from the Council of Governors meeting held on the 9th of May, which I will take as read. But are there any questions from colleagues? Just again to thank, and I know we have some on the call today, all of our governors for their hard work. There are volunteers as well, and I know commit substantial proportions of their time to helping us as a trust. We'll therefore move on to the Audit Committee report for the 10th of April. But before we do, I just want to publicly thank Richard Colley, who was our chair of the Audit Committee, for his 2 years of service to us as a trust. Richard, we wish you well for the future. And Oliver Koffler has kindly volunteered to become the interim chair of audit. So Oliver, anything you'd care to extract from the report of the 10th of April?
Thanks, Russell. Yeah, just very briefly, external audit, we had an interim update. We're on track for the final audit at the end of June. We're reviewing the annual accounts and annual report and extraordinary audit on the 19th of June. We had the internal audit reviews. We got significant assurance for contracted out payroll, which was focused around Civica. There is that note that there's been some challenges on bank payroll, which is internal, but we'll have a chat to the internal audit team to understand whether they can support us on that as well. And we'll pick that up at the next audit committee. We had a mask face follow-up review, slow progress made, still some more focus needed. We carried out the annual self-assessment, which is in the pack for people's reference. Some mixed set of scores, but there was a very low response rate. Only 5 of 24 people responded because there was some IT or some mail issues. So we'll take that and we'll move forward with it. We had the Information Governance Security Report, and the key thing to note out is going well. The Information Governance team won the National Team of the Year Award at the Information Governance Awards, so congratulations to them. And we had the Board Assurance Framework Report, and no major changes from there. That's all to mention.
Thank you very much, Oliver, and thank you for stepping up. Any questions or perspectives to Oliver? Okay, I think that review of what went wrong with the bank payroll would be good on the system issues there, Oliver. We'll therefore move on to the Clinical Governance Committee report for the 10th of April and the 8th of May. David, what would you care to pull out?
I'd take them as read, really, and I'll just draw people's attention to the points that I make, areas of concern, which actually some of them are actually improvements rather than, and I think it's quite important that we flag things where there's been significant improvement as well.
No, absolutely, David. Thank you. Any questions or perspectives to David? And Fiona, I know the hard work you and your team put behind the scenes on that, so thank you. Okay, we'll move on then to the capital programme. What an incredibly busy time it is, Jenny. You, Sophie and all the team in the States do a phenomenal job. What would you care to pull out of this?
Thank you. So just to say, this is the wrap up of last year's programme, just due to the reporting cycle that's come this month. At next board, there'll be an update on this year's programme, which we're already a quarter of the way through. So just to say, as you say, over a great year, just a small underspend. And just a big thank you to all the teams involved for the significant progress on the elective hub development, which will obviously continue into this year.
Yeah, no, thank you, Jenny. And I would just like, again, despite the phenomenal and the pace of work that's going on our estates is extraordinary, to apologise to members of the public and also to staff on the car parking issue. We know this is a very suboptimal period, particularly if you're frail and elderly and you've got the stress of visiting the trust for an appointment. We know car parking is very, very problematic, and all I can do is apologise and say that the payment will be worth it for future patients and their families and members of staff. Okay, if there are no questions to Jenny, then we'll just move on to some items for noting and information. The summary of ratified policies. Adam, anything you'd like to put out of this?
7 policies ratified over the last 2 months, but I'll take the report as read, Chair.
Okay, thank you, Adam. And any questions or perspectives to Adam on the ratified policies? Okay, the summary of safeguarding children, young people and vulnerable adults annual report. Fiona?
Yeah, this is a very condensed version of a long report that goes to clinical governance on a quarterly basis. Really shows in the last year that the demand on safeguarding has increased, particularly the complexity of cases, domestic abuse and domestic homicide cases across the county is putting a significant strain, both mentally and psychologically, to the team, but also just the work behind investigating those cases. But actually, the safeguarding position within our own organisation in terms of training and awareness and visibility of the team has really improved. So thank you to the team for that.
Thank you, Fiona. Any questions or perspectives on that report? Just a couple of points I'd like to make is an enormous vote of thanks to our ED and McGregor teams in particular for when they're having to deal with some extremely troubled children or troubled adults who in the ED department arrive. The second point I'd like to make is I do find it horrifying, and I talked about it this morning, the fact that 10% of women in Warwickshire have suffered domestic violence. Our frontline teams are trained to help you if you do suffer any sort of domestic abuse. So when you do visit the trust, if you need help, we're here to help you. And there are, through the web and other routes, ways of getting the help you need. No person should be subject to domestic violence and domestic abuse. Thank you everyone for your hard work in all of those areas. The summary of security standards 6-month report. Harkamel.
Thank you. So this is just an update that I bring every 6 months around where we're up to with our security standards. If we are not compliant with one standard in its entirety, we have to rate ourselves as either partially or not complete. So I'm really pleased that we are at least partially in the majority of actions. So out of the 43 areas, we've got 16 where we're showing us not completely compliant, and there is an action plan included as part of my report.
Okay, great, thank you. And always prefers to be heavily critical of ourselves, Harkamel. Any questions or perspectives on this? Okay, duly noted, thank you. And so we'll move on then to the Health and Wellbeing 6 monthly report. Gertie.
Thank you, Russell. Again, as Farquhar's just said, this is a 6 monthly report I bring to board. So I'll take the report as read. There's a few little bits I'll pull out. The detailed progress in terms of the expanded health and wellbeing services to our colleagues and progress against the 4 priorities. And again, we can see some really positive progress, particularly around menopause, mental health and wellbeing, and the health kiosks that have been extended, for another year. Both the menopause and health kiosks are initiatives that we're doing, working collaboratively across the system and are funded through the system. So it's a great opportunity for us to support our colleagues. The only other point I take out is there have been some changes to the team. I think I'd like to formally note, if I may, our thanks to Justine Whitmore, who's acted as the head of health and wellbeing for the past 3 years. And we have seen health and wellbeing grow significantly and the support to our staff with Justine's leadership. She has moved on to another role now in George Eliot. We have appointed a new colleague, a slightly revised structure to replace Justine, and I will be arranging for Ollie as our health and wellbeing guardian for wellbeing to meet with myself and Sam Cooper, who's our new colleague who's started just this week. I think within that, Chair, I'll happy to take any questions.
Thank you very much, Gertie, and a really broad portfolio of activities we have in place. And I would say to members of staff, if you've got a health and wellbeing issue, there's no need to suffer in silence. As your employer, we're here to help you and we want to help you. Any questions or perspectives to Gertie? Okay, I think we're on then to the updated Register of Directors and Register of Directors' interests. Sarah?
Thank you, Russell. So both registers have been updated with recent changes, which are detailed in the report. So happy to take the report as read and any questions. Thank you.
And any questions to Sarah? Okay, thank you. So they're duly noted. So we're then on just, I think, to some board committee minutes. Oliver, anything you wanted to add to the minutes of the 14th of February?
No, I don't think so. No, that's fine. Thank you.
Thank you, Oliver. Any questions on those minutes? And the clinical governance minutes of the 13th of March to the 10th of April. David, anything you'd like to add?
No, nothing to add from me.
Okay, any questions to David? Any other business then, team? Could you please raise a digital hand if you've got any other business? Okay, thank you. So I think we're on to questions from members of the public. I'm aware of one, I think, Sarah, from Roger. Would you care to read out Roger's question to us, please?
Thank you. So Roger notes that much of the trust funding is based on block contracts, and in view of the increases in attendances and activities funded by this method, has the trust been successful in raising the block payments base to reflect the higher base load of activity? Kim, I believe you're going to answer this question. Thank you.
Yeah, no, thank you for that. So just to confirm, we did not receive a fair share of the growth monies that were allocated to the ICB, but we did manage, after very challenging negotiations, to secure £2.5 million towards that growth, and also secured non-current funding for of £1.7 million towards our Sero beds. Any changes or growth as a result of a different out of area flows, or indeed into Coventry and Warwickshire system flows, are not reflected in the finances, as ICBs, not just our ICB, but across the country, are not revisiting a change in the share of allocations between ICBs or providers. But just some reassurance as well, 24% of our patient-related income is still variable, and that relates to the elective recovery fund and also specialised commissioned drugs. and also any activity that comes from the Birmingham and Solihull ICB.
So
Hopefully, yeah.
So it's simplest, Kim, you know, block hasn't increased as much as we'd like. So we're trying to max out on those areas where there's a version of payment by results. Yeah. Thank you. Glenn, anything you want to add to that?
Yeah, there is a bit of work underway nationally at the moment, which I'm linked into, which is looking at some better tariffs for urgent care, which would include some measures of some of the best practice tariffs, like the frailty model that we have. So I hope that it becomes a bit more responsive to increases in demand, certainly the increases in demand that we're seeing.
No, great. Thank you, Glenn. And any other questions from members of the public who are just on the line now? If you raise a digital hand or come off mute. Okay, I can't see anyone coming off mute or raising of a digital hand. So lovely to see you all. I look forward to seeing you at our next meeting. I'm just getting the date right. Help me, Sarah, please. So I look forward to seeing you at the next date on the, I think it's the
3rd of July.
3rd of July, day before my anniversary, so I should remember it. In the meantime, I hope you all stay well. Can I suggest to colleagues we have a 10-minute comfort break and get back for the confidential board at 3:55 to 4. So I will see you then, board colleagues. Thank you very much, everyone. Take care.